Good afternoon, everyone, and welcome to our webinar on nutrition support for orthopedic surgeries, what to know before and after. This webinar could not be done without the very generous support of Abbott Nutrition. And it's a collaboration between the American College of Perioperative Medicine, which I lead, and Abbott Nutrition. Now, about 4 years ago, we put up a boot camp, and the boot camp talked about perioperative care. And we had a Friday afternoon session on cardiac. And within that cardiac, I put an hour in on nutrition. And the first 10 minutes, the audience did not have a clue. Why do I even include nutrition in cardiac surgery? And honestly, I was shocked. But then again, I realized it really reflected more of how people thought about nutrition in the past. Well, the way we think about nutrition has changed dramatically over the past few years. And we now understand that nutrition is simply a part of excellent perioperative care. And I'm not going to say it will affect as much as the surgical technique, because nothing does, but it is really, really important. So it's my pleasure to have everybody here today. Next slide, please. We want to go through a few housekeeping items. At the first part of this session, we are going to have 3 amazing speakers. We're going to start from the macro to the more micro. And after that, we're going to have a case discussion. And in the case discussion, we'll have a case scenario, and then people will reflect on it. And then there'll be a huge opportunity to ask Q&A, so stay with us. If you have any technical issues, please let us know immediately through the chat so we can help you. There's going to be handouts emailed to all the attendees after the webinar is over, and we are going to let everybody know where we're going to post the webinar or recording of the webinar, so you can access it and tell all your friends and family about the webinar. Now, you are in a listen and view only mode, so please just make sure that your microphone and camera are disabled. And there is you can see the icon for the where you're going to put in the questions right there at the bottom. Next slide, please. I do want to remind the disclosures. We have support for the program from Abbott Nutrition, although the program itself is by the American College of Perioperative Medicine, and we do not intend it to give CME credits. The slides were developed by the speakers with input from Abbott and the society. With that in mind, we are now going to move to the first speaker, and Dr. David Evans. And Dr. Evans is a trauma surgeon. He's also the director of the nutrition program, and I have met him in a meeting about 3 or 4 months ago, and whatever I knew about nutrition, he exponentially increased it. So I'm very excited to have him on. And David is going to talk about the fundamentals of nutrition within the surgical settings. David?
Thank you. It's an honor to be here today speaking with you, and very excited to have so many attendees on tonight. Of course, I do want to disclose that I've been working with Abbott in research, speaking, advisory boards, also in TPN space as well. And so what I want to talk tonight about is optimizing patients preoperatively and finding the right nutrition support for them. How often do we stop and think about, is this patient nutritionally ready for surgery? And really, everybody probably should be optimized. And so I really want to think about it from that perspective tonight. If, I'm going to go from simple to more complicated as this talk goes on. And I just wanted to introduce you. If there are only 2 questions that you could incorporate into your into your intake screening forms or questions that you would ask your patients. One is, have you been losing weight, and how much weight have you lost? And the other question would be, have you been eating poorly because of a decreased appetite? This is the MST tool. And if patients say yes to both of those or have 2 points based on the weight loss, then that's going to be a patient who is at risk. They've been losing weight. They're probably malnourished. Why does this matter? Why do we care? Well, it really comes down to, how are our patients going to do after surgery? Are they going to be able to heal? Are they going to be able to heal their wound? Are they going to be able to heal the bone? In my case, in gastrointestinal and trauma surgery, are they going to be able to heal the anastomosis that we make? And we know that we need a combination of epithelialization, fibroblast ingrowth, collagen laydown, angiogenesis. All of those things are necessary in order to get good healing. And so, what we need to do is identify those patients who are at risk for a non healing wound, make sure that they have adequate energy and protein delivery to achieve the healing that they need. One of the big concerns is that patients who have lost muscle mass, you can talk about this in terms of lean muscle mass, lean body mass, or of course weight loss in general. If patients have lost protein, they preferentially are not going to shift the protein intake that they do have to the wound. They're going to heal it, or they're going to shift it to their muscle. And so those patients who have significant loss of protein or weight loss preoperatively are at significant risk for the stasis in the wound for not healing. Now, there's a lot of overlap here tonight between the idea of muscle mass, sarcopenia, which is age related muscle mass, and perhaps just geriatric frailty as well. There's a lot of overlap. And, when I talk to researchers who are frailty researchers or geriatricians, we're often talking the same language, but maybe in different terminology. So, I don't want to discount that inactivity. I'm going to talk about exercise a bit. And then, of course, the hormonal changes of aging, the inflammation of aging, all of these factor in, and of course, any chronic disease that a patient may have. We know that those patients who don't have adequate muscle mass, in addition to their outcomes not being as good, they actually have higher healthcare costs. And if you look at the payer cost as well, this is data from the state of Michigan, from their Blue Cross Blue Shield statewide database. Those patients who were did not have significant muscle mass were much more expensive. So those in the lowest 10th percentile or so, $42,000 per gastrointestinal surgery hospitalization versus those who were 14,000 in that highest group. Well, so if we're talking about muscle, could we be talking about albumin and prealbumin? Well, yes and no. These actually are not valid proxy measures of the total body protein or the total muscle mass of the patient and really shouldn't be nutrition markers. What they are perhaps markers of nutrition risk or markers of inflammation. So they decline in the presence of inflammation, really regardless of the nutrition status. I could have a weightlifter who is injured or has a Crohn's flare, and despite being extremely muscular, their albumin and prealbumin drop precipitously. On the other end of the spectrum, I can have somebody who's chronically starved, inadequate food intake, um, and their albumin and prealbumin is fine until they get inflamed. So these are more markers of nutrition risk. Now, their normalization, I'm not saying don't look at it at all. And if you can get these numbers to normalize preoperatively, it re- it really reflects a reduction in that risk. So I think there's value in that. If you can get the inflammation under control, you can get the albumin and prealbumin up preoperatively. They're more likely to be anabolic. They're going to have fewer calorie and protein requirements in the postoperative period. We know that albumin, low albumin, is a marker of nutrition risk, specifically in orthopedic surgery. This is a new study just published in the last month or so, basically showing that preoperative hypoalbuminemia was associated with a higher likelihood of requiring admission postoperatively after orthopedic surgery. Um, also, more likely to be associated with a length of stay. This was data from the National Surgical Quality Improvement Program, but it's important to just understand that this isn't really the same thing as malnutrition per se. This isn't using the same diagnostic criteria, but it is a risk indicator. So there's a tool. I was part of a group a few years ago that had the opportunity to develop a tool that essentially combines those two key questions that I showed you earlier, but also adds BMI and adds albumin into the mix. And essentially, if patients trigger any of these four items, so are they low BMI, less than 18.5 if they're younger than 65, less than 20 if they're over age 65, have they had unplanned weight loss greater than 10% in the last 6 months? And have they been eating less than 50% of their normal diet in the last week? If any of those, or if their albumin is less than 3, we recommend a preoperative nutritional intervention. Um, and a true assessment rather than just a screen, a true assessment in those patients. Of course, we know that wounds need protein. We need more data, I think, in more surgical areas for this. But this is looking at wounds in geriatric populations. And really, in order to get to positive nitrogen balance, you need at least about 1.3 grams of protein per kilo per day. Um, and this is expressed in terms of grams of nitrogen. So that's why you don't see 1.3 on this slide. But we need to get a positive nitrogen balance if we're going to heal. But part of the problem too is that our protein delivery is not strategic. Too many of our patients eat a higher carbohydrate, low protein breakfast. The same may be at lunch, and then at least in the United States, you know, what are we going to do? Steak, hamburger, the big high protein dinner. But what we really need to do is focus on maximizing protein synthesis by dividing our protein throughout the day and delivering it in more equal doses. So, oral supplementation is so valuable in this in terms of, if you have a meal, perhaps breakfast, you're typically a carb based breakfast eater, adding an oral nutritional supplement, a protein shake, is going to be so valuable in terms of maximizing that opportunity for protein synthesis. So, what are our preoperative recommendations? So, this just in general, really across a broad variety of surgical indications, preoperative nutrition supplements for at least 7 days, 2 to 3 times a day, 18 grams of protein per dose. Consider immunonutrition. Encourage that. I'm going to talk about what that is in the last few minutes here. Um, and aim for at least 1.2 to 2 grams of protein per kilo per day. What's immunonutrition? These are specialized high protein formula um, that have additional pharmaconutrients. So they're high in arginine. We'll talk about that. They're elevated omega 3 fatty acids. We'll talk about that. They may have glutamine. Some of these products may have ribonucleic acids. I would just emphasize that really we don't have any data to support the use of the ribonucleic acids per se specifically. And then occasionally people have looked at the role of selenium as well. I think the keys on this slide, though, are the arginine and the omega 3s. What are our goals? So, by using these immunonutrients, we're trying to minimize or attenuate our excessive inflammatory responses. We're supplementing the conditionally essential nutrients, so particularly arginine is rapidly depleted. For example, in trauma patients, arginine levels go from normal to barely detectable within 18 to 24 hours of injury. And so these are amino acids that are depleted rapidly and need to be replaced in somebody who's having surgery or experiencing injury. And so we want to provide a nutritional state compatible with healing and recovery. What does arginine specifically do? Well, does a lot of great things for the immune system, stimulates T lymphocytes, increases immunoglobulin levels, improves the respiratory burst of the neutrophil. But I really want to draw your attention to the last 2 points here. Nitric oxide, of course, arginine is a precursor for nitric oxide. By getting our arginine levels, our nitric oxide levels up, we see increased tissue perfusion to wounds, to anastomoses, to potentially ischemic areas. That's very important. We also see that this can be converted into proline and polyamines, which are precursors and important roles in collagen formation. So you can see the body actually, evolutionarily, we can take arginine, we can shift it in a variety of directions. Certainly, we can shift it to just routine protein synthesis, but we can also convert it to the polyamines or the nitric oxide based on the need. Fish oil is the other key ingredient in these amino nutrition products. So DHA and EPA minimize the loss of lean body mass, prevent oxidative injuries, control and modulate gene expression, also generate some molecules that have emerged and we've learned a lot about in the last 10 or 15 years. The resolvins, the protectins, these specialized pro-resolving small molecules that appear to be present in picomolar concentrations and have key roles in modulating inflammation. So, EPA and DHA, I mean, many of us know these from thinking about pediatric growth and development, but they are so much more and go into so many different key pathways. There are numerous data. We could spend a whole hour or more just talking about this, but this is the most recent meta-analysis I saw. This was primarily in gastrointestinal cancer studies. That's where a lot of the data has come from in this, but seeing reductions in infectious complications, um, often cutting infections in half. Cutting length of stay. You often see studies 1.5 to 2 days is common. In this meta-analysis, 1.5 days. And in this meta-analysis, mortality was cut, odds ratio of 0.55, so a 45% reduction in mortality. So, what about real world? So those were clinical trials. This is real world data. So in Washington State, through a Washington State Quality Improvement Collaborative, they implemented a checklist for really across the whole state in their surgical practices, looking at elective colorectal procedures. And when they implemented preoperative immunonutrition, and they monitored a composite adverse event rate, so bad things happening, whether it's reintervention, reoperation, infection, anastomotic leak, or death, they saw the composite adverse events go from 9.4 to 7.1%. Unfortunately, this didn't hit their predefined p-value, but it's clearly there were many thousands of patients in this. It's clearly significant, a 25% reduction despite the statistics not checking out. And they did see that a slight statistically significant reduction in prolonged length of stay with the use of immunonutrition. But that was real world, just doing it ad hoc, not in a clinical trial. Um, what about other things we can do with nutrition? So, enhanced recovery, perioperative bundles. This has been a hot topic in the last, really, it came out 20 years ago, but in the United States, enhanced recovery has become very hot in the last 5 years. So, these are bundles of care, and I'm going to show you about that in a moment. But through these, we've been able to reduce length of stay, usually by about 2 days, reduce complications, reduce cost, and then in the GI world, reducing our time to GI tract recovery. And every dollar invested in enhanced recovery is bringing big returns. And that's Canadian data. On average, $639 reduction in cost. This is what a bundle can look like. So it's a lot of it's about patient education. It's about preparing the patient ahead of time, what they are going to need to do, what they anticipate doing. So it may be breathing exercises, early ambulation, non-opiate pain control, use of regional anesthesia techniques. Of course, I know the orthopedics world, you're really great on that already. Early nutrition, so use of liquids and protein drinks early on, moving to solid food rapidly. Um, for orthopedic surgery, I can't imagine why anyone needs to be on clears on post-op day 0 or post-op day 1. Just move straight on to oral supplements, high protein intake, and get your patients moving quickly. So with that brief overview, I really look forward to our discussion tonight. Thanks for having me.
Wonderful, David. Thank you so much for this overview. And what's particularly interesting to me, what you said about the albumin. I think a lot of us had the perception of albumin is a direct indicator of the nutritional status. So I'm actually looking forward to for the discussion part. Our second speaker is going to be Dr. Matthew Austin. Dr. Austin is the chief of the Division of Reconstruction Orthopedics at the Rothman Institute, if I can say the famed Rothman Institute, which is obviously part of or affiliated with the Thomas Jefferson University. And I must admit that the Rothman Institute had a very supportive relationship with our society. We're now going into year 5 of the conference, and Dr. Alex Vacara, who is their president and surgeon-in-chief, was a speaker in 3 out of the 4 conferences. So I have a very warm place for them. Matthew has published extensively and is the chair of the Committee on Evidence-Based Medicine of ACUS. I know they just had their annual meeting. And he's published extensively on the topic of nutrition. And so I'm looking forward to hear now from the macro, going more into the micro and understanding more about the role in orthopedic surgery. Matt?
Thank you, Dr. Kain. So I'm going to take what Dr. Evans talked about and narrow it down to the field of orthopedics. There is one relevant disclosure here. Our study we will introduce in this talk is sponsored by FAIR, which is basically from ACUS, just for disclosure purposes. So we know from Dr. Evans's talk that that pre-op patients have muscle atrophy, particularly orthopedic patients who have disuse atrophy. Surgery itself is trauma, and the initial response to this trauma is catabolic. In terms of the metabolic response, there are high levels of oxidative stress, hyperinflammation, immune system impairment, and insulin resistance. So herein lie an opportunity for nutritional supplementation. Why should we care about comorbidities like nutrition? Well, we all took this oath to try to do the best for patients and do no harm. However, in this day and age, when you talk about bundles that Dr. Evans talked about, the cost of Medicare alone for hip and knee replacement in 2016 was $7 billion. And so we care a lot more about comorbidities because there are dollar signs attached to comorbidities. In the past, everyone used to bill separately, receive separate reimbursement, and if there were complications, the payer, whether that's CMS or a commercial insurer, would pay out. With the introduction of bundles by CMS and private payers, this all goes into one bucket. So the payer is no longer paying extra money, so to speak. The bundle, the complications and the costs associated with those complications are taken out of that dollar figure. So just as an example, if you look at periprosthetic infection, this study published from our institution showed that if someone gets an infection, it's basically $50,000. It's a $12,000 hit on the readmission and $34,000 hit on the post-acute acute care costs. So it can be quite expensive. The cost of malnutrition, and again, we're simple orthopedic surgeons. We're not like Dr. Evans. We're going to call low albumin malnutrition, even though we know it really isn't, but it's a quick marker, and orthopedic surgeons are fairly simple in that way. So we'll call it malnutrition, even though it really isn't. And the cost of malnutrition is almost $10,000 when you look at the complications associated with malnutrition. And you can even add more to that for obesity and uncontrolled diabetes, which are related to nutrition. In this study from Stanford, they looked at medical and surgical complications and found them higher, much higher in malnourished patients. And this resulted in almost a $4,000 loss per patient in malnourished patients because of their complications. After bundled payments, there were formal risk assessment protocols put in place. Our particular questionnaire has 43 medical questions and 15 social questions, and we're risk score the patients as a result of their answers to these questions. This slide basically shows now we have an all-encompassing process where the patients are evaluated, they're optimized, and then finally cleared, so to speak, for surgery once they are optimized. And nutrition is a very important part of that optimization process. So let's talk about different types of risk factors. There's modifiable, non-modifiable, controlled, uncontrolled. Some patients have high-risk diseases. Some patients have non-modifiable risk factors, but there's an intense focus because of bundled payments on modifiable risk factors. So what are these? These are smoking, nutritional status, obesity, diabetes, substance dependence, and bacterial colonization. These are now viewed as modifiable risk factors, not only within the medical community, but by the payers as well, and that is important. How does the international community feel about risk factors? So this was the second international consensus meeting organized by one of my partners, Jay Parvizi, and a surgeon, Thorsten Gerke from Germany. There are over 546 delegates from over 100 countries. There was a modified Delphi process, and this had to do everything with risk factors for infection, diagnosis of infection, treatment of infection. So one of the questions that was asked of the process was, should we modify a modifiable risk factor? And 90%, based on strong evidence of the delegates at the meeting, believe that surgery should be deferred in patients with uncontrolled conditions like malnutrition. Now, another key question is, what happens if we modify a risk factor? And basically, we don't know. 98% agree that currently there is insufficient evidence to prove that correction of preoperative nutritional markers reduces the risk of subsequent PJI. How prevalent is it in the arthroplasty community? Well, about a quarter of our patients are malnourished if you use hypoalbuminemia as a criteria. We know that it affects wound healing. This is a This is a meta-analysis from the Hospital for Special Surgery that shows that malnutrition is associated with wound complications after orthopedic joint replacement surgery. This is a paper from our institution, and we found that when you look at the bottom of table 2, any complication was statistically more significant in patients who had low albumin, 12% versus 2.9%. Interestingly, we found that those under 55 years of age, most of the time did not have a low albumin level. So in summary for malnutrition, the prevalence in the literature is anywhere from 26 to 50% in the orthopedic joint replacement population. The risks involved include increased risks of infection, length of stay, readmission, failure of IND, and cost. The tests to order there are displayed there, but we often focus on albumin in the orthopedic literature. So what is the optimal cutoff? This study from Duke found the optimal cutoff for albumin levels was 3.9, which is sort of interesting since most studies use 3.5 or 3.4 as the cutoff. And then the impact of correction is largely unknown. There are no high-level studies in the elective arthroplasty population. There's been a focus on protein supplements, iron supplementation, vitamin D, vitamin C, and zinc, but no real outcome studies. So some preliminary evidence, this prospective double-blind randomized study when 60 patients won this Ranawat Award. They supplemented patients for 1 week pre-op with an amino acid supplementation and 2 weeks post-op. The outcome measure was rectus femoris muscle area on ultrasound and return to ADLs. And they found that amino acid supplementation prevented atrophy and accelerated return to ADLs in this patient population. This other study looked at a 5-hospital system with 4,700 patients. One hospital in that system had about half the patients, and they had a nutritional intervention program for patients with an albumin less than 3.5. There were 543 total malnourished patients, and they found that the intervention group had shorter length of stay and charges. So because of this lack of evidence, my group and the NYU group got together and we designed this multi-center study, and we were the recent recipient of a very generous $50,000 grant from the Foundation for Arthroplasty Research and Education. And basically what we're doing is we're doing a prospective crossover study. So at the current moment at Thomas Jefferson University Hospital, what we're doing is we're screening patients. If we find they're malnourished, we just observe them. The NYU group, on the other hand, if they find a malnourished patient, according to albumin, again, I know it's not really malnourishment, but it's a nourishment risk factor, they undergo supplementation for 2 weeks before surgery and for 2 weeks after. And we were looking at outcomes. The pre-hoc power analysis said we needed 700 patients, so it's going to take us a little while. Some additional interesting areas are carbohydrate loading. This may increase insulin-like growth factor 1 levels. It may reduce hunger and nausea. It may attenuate insulin resistance and glucose release after surgery. But again, there's no high-quality evidence in the total joint arthroplasty literature yet. When looking at low levels of vitamin D, the prevalence in arthroplasty patients is quite high. Over half are insufficient and almost 40% are deficient. However, there's insufficient evidence to correlate with complications at this time, and therefore the effect of screening and correction is largely unknown. So, like Einstein said, if we knew what we were doing, we would not call it research, would we? So hypoalbuminemia is quite prevalent in the total joint population. It's associated with a number of complications. We have an unknown effective intervention, and further study is necessary, and hopefully we'll have the data that shows that getting malnourished patients or patients with low albumin with normal levels will reduce their complications, and that will be a pretty good and useful practical way to lower complications. So thank you once again for having me, and I appreciate the opportunity.
Thank you, Dr. Austin. And one of the things we will do during the case study, I personally want to get a bit more clarification on the whole issue of albumin here, because there are a couple of questions about it as well. So we will talk about it. Now, our third speaker is Dr. Ira Kirschenbaum. And Dr. Kirschenbaum is the chair of orthopedic surgery at the Bronx Care System. And a small amount of information here is Dr. Kirschenbaum, Dr. Austin trained at the same institution just a few years apart, but that's neither here nor there. The one thing I want to say about Ira is that, I have actually met him through LinkedIn, and he is very active. He publishes a tremendous amount there, and he's an editor of a journal of orthopedic experience in innovation, which is an entirely open journal, and I highly recommend to everybody check it out and publish it. There is no fee associated with it. So he's really trying to promote education in that area. Dr. Kirschenbaum is going to talk about telemedicine overall, and then telemedicine and nutrition in the next 10 to 15 minutes. Dr. Kirschenbaum?
Yes, thank you. Thank you for that introduction. And you can see that I trained 25 years after Matt Austin, so works out pretty well. I am going to share my screen and get going. So what we're going to talk about a little bit right now is execution of things that you have learned, because one of the hardest things that I have found, and I am the chair, not only of orthopedics, but the clinical chair of the telehealth program of a 1.15 million patient health plan system in the South Bronx. We are in the poorest congressional district in the United States. And we're just publishing an article on comorbidities, which we have close to 75% of our patients have more than 4 major comorbidities. And malnutrition probably is quite rampant. But what we found, and what I'm going to talk about today, is the execution of what you've learned through telehealth and its use in episode of care management. Because execution of what you learn is going to be the most important part of what we're here and what it's all about. So disclosures, Medscape, I'm the editor of Orthopedics. Dr. Kain already talked about the new journal we started. I'm one of the co-founders of SwiftPath, and that's the biggest disclosure. Of course, it's an episode of care management company. So managing an episode of care, nutrition has to be considered part of the episode of care of orthopedics. And in fact, we're changing our joint replacement model here at our hospital to manage the episode of care of joint replacement from pre-op to post-op with at least 50% telehealth, because patients need access multiple times to reinforce complex things that you are trying to explain to them, specifically about nutrition, specifically about how to care for themselves post-operatively. It's a process that needs a team, that needs exquisite planning, resources, schedule, and management. Everything that you hear about today has to be part of an episode of care. It's not about an encounter. You don't send somebody to a dietitian. You don't send somebody to a pre-op clearance. They all are integrated into an episode of care, and probably nothing manages an episode of care better than telehealth, because the right telehealth program can keep track of every one of these pieces of the episode of care. We tend in orthopedics to take quite a microscopic look at joint replacement and think it's all about the implant, but it's not. And nutrition, of course, as we've heard before, plays a major role as a modifiable risk factor on both ends, of course, the obesity end as well as the heavily malnourished end. But I will certainly say that the frequency with which you can reach the patient through the episode of care is highly magnified with the right telehealth program. The telehealth program has to have a number of very important features. Number one, it has to have ease and convenience to the patients. We found in indigent areas such as the South Bronx, where only 6 to 8% of our patients actually have internet access. And you'd be amazed how few people in the country still have consistent internet access. We have found the use of cloud programming, through SMS text messaging, and ease of convenience to the patients and reaching them that way is critical. You need connection eventually to remote monitoring. You're going to see an explosion of remote patient monitoring programs. Some of them will be billable, some of them won't. Many will add to the episode of care in the value-based payment model. Additionally, you're going to need a connection of all these telehealth into patient portals so you can document everything that you did with every visit as you're monitoring the patient. You will notice that telehealth will increase your frequency of interactions. And when managing a complex episode of care that joint replacement is, that major spine surgery is, trauma surgery, a whole range of orthopedic problems, the frequency with which you can connect with that patient will prevent emergency room visits and will prevent readmissions to the hospital. We're in a process of publishing a paper of 1,000 consecutive patients looking at ER admissions as well as hospital admissions, ER visits and hospital admissions in this type of community that we're in. And we are finding numbers close to 30% of ED visits. And that's going to destroy your bundle and take all the money out of your pockets if you don't have frequency of interactions. You also need to integrate telehealth with other episodes of care because the patient may have joint replacement, but eventually have their endoscopic surgery and all other types of aspects that can all be managed through telehealth. There are huge numbers of papers that are out there that talk about managing nutrition therapy on telehealth is comparable to that done in person. And it's important to keep in mind as you move ahead that if you don't have a healthy telehealth program, you probably won't have a healthy ancillary care or a nutrition program. The basics of a telehealth solution: cloud-based, always better than app-based. You have to know your community. Socioeconomic issues are very important. Not everybody can connect through your internet portal or go through a website, especially if they have limited data plans or they live in countries around the world where internet access is more limited. You have to be able to function on multiple platforms. You also need a standard protocol of how you're going to do telehealth. One of the things we're doing at our institution is all the departments are being asked to develop standard protocols of what a telehealth visit actually will accomplish, rather than just saying hello to the patients. This will give us standard questions to go back and do research on and to see how well we're doing here. You need to incorporate remote monitoring, which is really in its infancy right now. I would not say it's quite advanced. And another thing that many telehealth companies don't talk about is interpreter incorporation. I work in a population that is 65 to 70% non-English speaking, predominantly Spanish. I speak fluent orthopedic Spanish, if that's such a thing. But the reality is interpreter incorporation into your telehealth is going to be critical. So I just thank you for this sort of brief introduction about using telehealth into the episode of care management.
Thank you, Ira, and thank you for all our speakers. As a next step, we are now going to move the next slide forward. And the next slide forward is a case study. So I'm going to read the case study while the other panelists, including Dr. Evans, are going to be on the camera again. So this is an 81-year-old male who has a history of coronary artery disease, diabetes, and a BMI of 16. He's scheduled to undergo a total joint arthroplasty. His family reports the patient, who is a veteran, by the way, to live at home, and he's somewhat frail and weak, and he smokes about a pack of cigarettes a day. Labs show serum albumin of 3.3, a prealbumin of 14, a transferrin of 185, and a hemoglobin A1C of 8. Where should we start? Let's start at the beginning. First of all, does anyone have any other questions about this patient before we dive into it? Any additional information that you guys would have liked to have if this is a typical patient who comes to have surgery?
Well, has he had recent weight loss?
No recent weight loss.
Okay. Well, and how's his oral intake too? Those are my two key questions.
Well, he lives at home with his wife, and he's not eating well. His wife also suffers from a variety of illnesses, and the daughter says that he's kind of weak and frail. She doesn't know what, she heard this sentence from one of the primary care providers who told him that. But somehow he continues to smoke. You can't stop his smoking. And the orthopedic surgeon who has seen him said that he really needs the joint.
Dr. Kain, I just have a quick question. What is the sense of this patient support services? I mean, his wife is obviously sick. How involved are other people in their life? Do they have caregivers that come in on a weekly or daily basis? Do they have home health aides or anything of that nature?
So we have, his daughter lives right next to him, and his daughter is helping. And then they have somebody for 4 hours a day who's coming in as well. The patient is mobilizing and he is walking around at home, but he's not a jogger. How about that? He walks around at home, he watches TV, he goes next door to see his kids. And he's not expecting to go back to jog after the hip arthroplasty, but the feeling is that he really needs it.
So Dr. Kain, I would sort of look at this patient holistically. So it says in the case study that he was scheduled to undergo total joint arthroplasty. What I would tend to do with a patient like this is I would say, okay, let's assume they're an appropriate candidate for surgery. Number one, I think they should see their primary care physician, because I want to know how bad their coronary artery disease is, how well his diabetes is being managed. You know, at our institution, we use 8 hemoglobin A1C of 8 as a cutoff. It is not a perfect cutoff because, you know, probably the perioperative glucose levels are more important than the hemoglobin A1C, but you can't really have a patient show up the day of surgery, check a glucose level, and then cancel their surgery. So it gives us a reasonable idea of his control. He's on the borderline with a hemoglobin A1C of 8. Whatever you want to have the cutoff be, 7.5, 8.5, 8.
Well, there is a reason why I chose 8, because I wanted to see what you guys are going to say about it.
Yeah, so 8 in and of itself would be okay. It sort of meets our criteria at Rothman, but that's subject to debate. But you have to put the whole picture together. This patient is underweight. You told us he's not taking enough calories in. He's frail, and he also smokes. So he has a number of what we would consider modifiable risk factors. So I think a patient like this needs more of a holistic approach where we work with his primary care physician. He sees a nutritionist. He has his diabetes optimized. Maybe perhaps get his nutrition up to snuff with the nutritionist, and then reassess him for surgery down the line. Smoking cessation would be, I think, important for him. But again, just like nutrition, we don't know the effect of smoking cessation, because if he's been smoking for 50 years, stopping smoking for 4 weeks before surgery may not do the trick, but we don't know the answer to that. And incidentally, we also have a study going on smoking cessation. So there's a lot of unanswered questions in terms of modified risk factors.
Let me just jump for a second on the smoking cessation issue. Yes, it is a controversial issue. And there are some evidence, however, that even smoking for 4 weeks before surgery will improve the outcome. So I'm happy that you guys are doing the ultimate study, but you know, let's just remember that kind of in terms of what the textbooks are saying. So if the patient shows up in the pre-op clinic right now and he's scheduled for 2 weeks from now, would you say, yep, you're going in 2 weeks? Or would you say, hey, you know, this is not urgent. let's go back and we'll figure out how to optimize it, and then we'll give you a date.
I would take the latter answer. I would send him for optimization.
Ira, what do you think?
I would send them for optimization, but I'd also like to define optimization in the sense of who is going to really take ownership of this patient. You know, we can say the primary care physician, but if you're in a community that has 205 primary care physicians, what's the quality control of that level of perioperative care and management? So one of the options that we instituted here was we insist with the primary care providers and community that we take the patient away pre-op and we'll turn the patient back post-op, and we're going to own and do the optimization all the way through, so we get consistency about where we want to go. It's complex, but now the community has adopted that, and so we no longer truly accept primary care physician. We accept the input and advice and work with them, but the ownership goes with our perioperative team to optimize. And I think that's very critical, who owns these patients, because they get lost in the sauce. You say, no, don't do surgery. And they walk away, they get frustrated, they don't follow what nutrition says, and they just drift.
Yeah, I'm not just going to pose one question to you. Who is paying for all of this, Ira? Because I think this is the challenge always. Most of us are in a fragmented episodic care. And typically hospitals want to pay for the surgery itself. And so how do you get over the fact that who's going to pay for this apparatus that you're proposing?
Well, the way we do it is we look at the Part A collection that joint replacement brings in, okay? And we look at the cost of cancellations and the cost of missed opportunity. We are also at risk for about 25% of our healthcare, because one of the large payers in our area, we are a sponsor hospital. So we're at 25% of our patients have this health plan. So the healthier we make these patients, in the long run, we're winning on the risk management. We've been able to convince our CEO that this is the right thing to do. And financially, in the long run, with decreased cancellations, decreased readmissions, and increased quality leading to hopefully better incentive payments, it's going to pay off. Short run, you're spending money.
Yeah, I think you're very progressive. I don't know what the rest of the panel thinks, but it's complicated. That's all I'm going to say. I think that's where we need to go, exactly what you're saying. Any other comments?
Yeah.
Or should we?
Yeah, I mean, I agree. It's extremely complicated, and nobody really wants to take the cost on. But at the end of the day, it's going to get us when it comes down to either whether you're a bundled payment plan or you're being scored on a quality metric, and you get penalized at the end of the year because your readmissions were too high, something like that. Yeah. I want to just comment about this case though. In terms of what am I going to focus on? I mean, yes, for me, the BMI is probably the thing that jumped off the page, that this patient's at risk. That's the key risk here. Even that albumin, even though, we saw 3.9 as a potential cutoff, we're not below the 3.0, which I'm usually using. The pre-albumin is kind of marginal at the 14. So I'm not even sure that albumin and pre-albumin are serving us well in this patient, even though he's high risk in my book. But the modifiable risk factor here is probably that he's frail and he's weak. How does he feel? If we can do something to make him feel better before coming to the OR, I think that's really important. And so that's where the idea of prehabilitation is so important. So the idea of not just optimizing his nutrition, but also adding some sort of exercise program that's appropriate for this patient, that's going to help him build and maintain muscle mass. So I think ideally, in an ideal world, we would combine the exercise regimen education with those nutritional assessments. And when they do the food frequency questionnaire or the nutritional assessment, I think the key focus really needs to be on the protein intake and how can we strategize to get better protein intake for some period of time before surgery.
Yeah, one of the challenging things with an arthroplasty candidate is the fact that if you send them for prehabilitation, it's often a very painful process for the patient, and it's sometimes not successful if they have end stage disease. So that's one of the challenges.
Yeah.
Also,
Yeah.
this is a very unusual orthopedic case that Dr. Kain has selected. The patient has a BMI of 16. Usually our patients have paradoxical malnutrition in that they are overweight or obese, morbidly obese, and have low protein levels. So this is a rare case indeed.
Okay.
Yeah, and that
Well,
patient, yeah, they need high protein but low carbohydrates so you can achieve some weight loss while still building and maintaining muscle mass.
it is. Let's jump for a second and talk about the patient with the high BMI. And so choose a number, 30. I don't know what number you want to choose. What would you do with a patient like that?
So with a patient with a BMI of 30, that's not really where the risks go up in the orthopedic literature. Usually around 40 is what we're talking about. They start going up at around 35 significantly, but 40 is really where it skyrockets. And the super morbidly obese over 50 is at very high risk. So, I think the problem here is we identify, as same with this case study, we're identifying single risk factors. And so you can have a patient who has a BMI of 41, but has a lower risk probably than the patient that we see here if they have no other medical comorbidities. So right now we're in the stage of orthopedic surgery where we're identifying single risk factors and trying to correlate with them with complications and then correlating the correction with the reduction in complications. We're not quite there yet. So there's a patient with a BMI of 41 who is very healthy. They have a lot of muscle mass, which is the weakness of BMI, and they probably are at low risk if they're 55 years of age. But if you have a BMI of 48, you have metabolic disease with diabetes, obesity, then you're a very high risk candidate. And again, nutritional consultation for a high protein, low carbohydrate diet and other interventions, I think can greatly benefit those patients.
Yeah. I'm all about looking at the big picture, and there is a reason why I put the words frail and weak there. And obviously, frailty is the one biggest holistic predictor that's coming out now in the literature. And there's a lot when you say somebody's frail to it, including the nutritional aspects. Let's jump for a second of a few of the questions there, and I think you guys can see them as well. I'll just pick at some of them. For example, what is the role of the DEXA scan in patients prior to surgery when you're trying to evaluate malnutrition? Any role at all?
Well, in the general surgery literature, the DEXA probably falls behind CT scan because we tend to focus on that. I'm not sure how you all use it in ortho.
I think we just use the DEXA scan for for management of osteoporosis and osteopenia. So we have an osteoporosis management program that's handled by our medical physician. So we don't routinely get a DEXA scan preoperatively, but if we notice that a patient is at risk for osteopenia and osteoporosis, they're sent to our management program.
Okay, that makes sense. What about the role of a registered dietitian in everything you guys have spoken about so far? Talk to me about that for a second.
Well, I think that, again, you have to organize the team correctly. Sending someone to a registered dietitian could be a one-off. We see this too often in our community where we send for a consultation, they write a consultation, someone sees it. Again, I'll go back to the concept that the registered dietitian has to be part of an integrated team that has someone who has ownership of what that dietitian is going to say and apply that directly to the patient care and execute the problem, execute a solution to the problem. One of the questions someone answered, and I think insurance companies play a big role in this, they so easily will pay for a pharmaceutical, but they won't pay for nutritional support. You know, for if you believe in, vitamins and Ensure and, so many things that could help in nutritional support, the insurance companies just don't have that model. So getting that ownership of a person who's owning the episode of care will enhance what the dietitian says significantly. Otherwise, it ends up being a one-off consult, in my opinion.
Yeah, I must admit that the whole concept of the perioperative surgical home, which some of the audience may be familiar with, when we started it about 5 years ago, it was all about the fact that on a typical joint patient, you may have 40, 50 people who are dealing with the patient, and everybody is doing kind of their own work at some points, but there is a lack of an integrated model, except for places like Rothman, for example, which obviously you guys have 160 surgeons, so you may have an entire process lined out. But for most hospitals, they don't really have it. So the question is, how do you integrate the model? How do you have a care team? And how do you make sure that people look at outcome and identify that the better outcome may necessitate a higher investment a priori? And that's a concept that sometimes is hard to figure out, because in a hospital, if you're looking at lengths of stay, and that's in the cost center of lengths of stay, and then you have the cost center of the surgery, and there are two separate cost centers in the hospital, then the surgery cost center may refuse to pay for the dietitian and all that, because it doesn't affect the surgery, it affects the recovery after surgery. So that's one of the challenges that we all need to kind of get through when we talk about this. Okay, we talked about albumin a few times here, and I want to leave the audience with a solid recommendation on the topic. So I'm going to do a black and white. Should you or should you not get albumin before surgery for patients who you suspect may have some nutritional issues? And please, if you can do a yes or no, that would be great, because I think the audience needs to know the answer rather than a discussion.
Yes.
Yes.
I mean, yes.
Okay, so the answer is yes. And I'm going to pick on David just for a second, because we heard that it's not a great indicator, but can we now say that overall, if you have a patient just like I described and the albumin is lower, then you probably need to be more anxious than otherwise?
Absolutely. And it's a marker of nutrition risk. So not just, while I still am not going to let anybody say it's malnutrition, it's nutrition risk that will benefit from nutritional supplementation. I think we just need to be a little more holistic about it. Also represents inflammation or something else. And so we need to make sure that we're addressing all those comorbidities. And there actually is data, particularly in gastrointestinal surgery, that if we modify the albumin preoperatively, if we get it to go up, whether that's with oral supplements, TPN, enteral feeds, nutrition consult, or just a delay, a flat out delay that you wait another month to let them get over whatever happened to them before, that their outcomes are going to be better. So you can get the albumin to go up, and I recommend that you do.
Okay, so if we accept that albumin is good, but there are all these caveats, is there another biomarker that we can use? I see the smile, David. Is there another biomarker is there that we can use, or really that's what we should do?
Well, it's not a lab, but it's whatever you can do to get closest to the idea of muscle mass. You know, while I've been pushing CT scan, I mean, DEXA might be an option if you do it differently than how it's usually used in ortho. But probably functional status, like a time stair climb, actually outperforms the NSQIP risk calculator. It outperforms the albumin. It outperforms the CT assessments of muscle mass. Just basically a time stair climb. You know, if you have a stairway at the end of your office, send them down the stairs and back up. I understand if we're talking about total joints, that may not be the best population for that, but that time stair climb is so strong.
I'm going to have one last question here, and it's an orthopedic question. It actually talks about lumbar spine, but I'm going to just convert it to joint. And so the question is, how quickly would you recommend to advance the diet if a patient after a hip replacement is experiencing abdominal distension post-op, You mentioned in orthopedic surgery, the diet should advance straight to regular post-op, question mark. I'm reading the way it is, so please feel to elaborate on the topic.
Well, certainly abdominal distension I would consider a warning sign. So significant nausea and vomiting, abdominal distension, those would probably be reasons to go slower. Still, though, if you're going to be on clears, try to find ways to get protein into the diet. There are like fruit juices that are specially supplemented with extra protein. Think about yogurts, think about other ways to slip protein in, even if you are doing kind of a tolerance diet. I would not go straight to NPO. And then, in your enhanced recovery, try to be aggressive with your antiemetics, both pre and post operatively. The carbohydrate loading appears to improve the tolerance post op. I know Dr. Austin mentioned that briefly. We want to be on this. We don't want to just make these patients NPO.
Yeah, makes sense. Dr. Austin and Dr. Kirschenbaum, any last words?
No, I thought this was great. I just think that as surgeons, especially orthopedic surgeons in the past, we really didn't pay much attention to the patient's medical problems. And one of the positives of bundled payments is that we are now focused on the whole patient and their episode of care. And I think that's a good thing.
Great. So again, David, Matt, and Ira, thank you so much for being here today. Thank you so much for the Abbott team, Kathy, Dr. Higazi, all the teams, all the people in Abbott. We could not have put it up if they wouldn't have helped so much. We're going to post this, and everybody's going to get an email with a handout and with a web link of where we're going to post it. And feel free to share it. And again, thank you, everybody, and have a wonderful weekend. Thanks. Bye-bye.
Thank you.